All right, Kinesiology 230, Chapter 21. Here we are, presentation 4 of 4. We're talking about the ankle, knee, hip, and some arthritis. Um, it's about 8 pages of content in the book, and it's going to be about 10 slides. So let's get her done. So ankle sprains are one of the more common sports-related injuries, so says the book, and I agree with that. The inversion sprain itself, which is a sprain of the anterior talofibular ligament, you get over here, anterior talofibular ligament, this guy right in here. That's the one that is injured the most. And the book notes that if you injure the posterior or the calcaneofibular tendon itself, those would denote a much more serious ankle sprain. But usually it's the ATF, the anterior talofibular, which is, again, that guy right here. That's your winner. Um, with an inversion ankle sprain itself, with movement, you're going to stay away from any kind of movement pattern that includes inversion, perhaps even just weight bearing in general. Uh, Exercise contraindications, any kind of loading or full weight bearing based on pain or mobility. And then what they suggest is or are open chain, range of motion exercises, and strength activities until weight bearing is permitted. And it's going to be gradual too. You're going to have probably a little bit of taping going on, a little trip to the training room to get your ankles taped before you go out to practice. But it's part of being an athlete. Almost everybody has sprained an ankle at some point. So they know 3 common conditions with the knee: anterior knee pain, anterior cruciate ligament injury, or total knee arthroplasty, commonly known as a TKA. So, youth athletes will also many times experience a growth spurt. I think I might have mentioned it in another presentation. You work with a client on a Tuesday who's 12 years old, and they come back, the next week, and all of a sudden they're an inch and a half taller because they got a growth spurt over the week that they were gone. And you're like, holy smokes, and they're like a fish out of water. They have to relearn everything. Well, youth athletes oftentimes will have discomfort in the patellar tendon just below the kneecap. So it's not so much a knee injury per se, but they'll have discomfort in the knee because what's happening is they grew so fast, it basically has stretched or elongated the tendons, and it's compressing the sesamoid bone, the patella, into the knee joint every time they bend their knees. So they end up with like this soreness and stiffness in their knees. And that's just a matter of they got a growth spurt, their bones grew, but their tendons have to catch up. That's just part of the deal. So you have to be smart when you're training youth athletes and knowing just how hard and how much to push somebody along so you don't blow a tendon. Okay. Now, you'll have clients come in who are older who will have like this crepitus sound. It's a cracking or creaking in the knees every time they get up. They might be a little bit stiff, and they'll feel it. They might even hear it. You might hear it. But if you have them just do a seated, unloaded knee extension, almost like doing a leg extension with weights, but without the weights, you can just palpate and put your hand right on the side of the kneecap, and you'll feel that click, 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 creak, 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 creak as they're going up and down. And it's usually attributed to like the kneecap itself. If we were to pull the kneecap off and look at the underside, the cartilage that there deteriorates with time. It becomes rough. There's like a little softening to it. And that roughness causes what's called chondromalacia. And that chondromalacia itself is the roughness that causes that clicking and popping sound, which is crepitus. So if you want some fancy terms when your client comes in and sits down with you and they say their knees are clicking, like, oh, you're saying crepitus, and that's usually caused by chondromalacia. And it's just a matter of the commonality of that is prevalent. I mean, I can't tell you how many clients I've had who've come in and say they have knee issues because of that creaking or cracking. Now, here's the thing, you may have clients who have creaking or cracking and pain, and the pain becomes a limiting factor in their ability to perform exercise. And yeah, I had a conversation with one person who was a client, not a client of mine, but she was a client of a trainer in the fitness studio over at Harper. And she was mentioning about how she had soreness in her knees and she can't stand leg extension, yet her trainer wants her to do leg extension because that person believed that it should hurt so good and blah, 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 blah. It's like, no, absolutely not. That should not be the case. If you have cracking or creaking, that's not really a contraindication per se. You can kind of work through that. But if it's creaking and cracking with pain, then that's a limiting factor. So you have to be smart about what you push your clients to do. Now, they talk about here in table 21.7 exercise guidelines for the knee relative to the diagnosis. So the diagnosis on the left here, anterior knee pain, if I get my mouse, anterior knee pain and ACL reconstruction, total knee arthroplasty. So for example, after an ACL reconstruction, end range knee extension is contraindicated. Just saying, that might be something you want to remember for later. But if you look at this, maybe like when you have clients down the road, if you have somebody with anterior knee pain, you're going to stay away from these movement patterns and stay away from these exercises, and then get into maybe these types of exercises here, right? So maybe pause me and just kind of read through these if you don't have access to this in the book. So with an ACL reconstruction, it's usually a catastrophic injury, and many times it's a non-contact injury. It's almost like a cutting type injury where a person's changing direction and they just happen to tear their ACL. So the book itself advocates the use of open and closed chain exercises. Now this is where it gets kind of funky, and I'll just provide a couple an example here so you can see the difference. Now an open kinetic chain exercise, the distal aspect of the extremity can move freely in space. And they note that examples of open kinetic chain exercises include straight leg raise, meaning like you're just raising your leg up and there's no weight on it, no resistance, you're not pushing against anything solid. Knee extension, and then they talk about leg curl or leg knee curl, or it'd be called knee flexion. And then you have hip flexion and extension. Now, what's quirky about this and a challenge is when we talk about leg extension. With leg extension, and it's a little bit of a brain bender, because in leg extension, can the distal end of the extremity actually move freely in space? It's pushing against the bar, and the bar is made of metal and wood, and so to some degree it's kind of stuck in a range of motion. But what you'll notice is it's the foot that's not pushing against anything, and the foot is actually in a stable place, right? Or able to move around. And it oftentimes is difficult to kind of wrap yourself around just the logic behind open and closed chain. But to a certain degree, you just have to keep in mind, if it looks like this, and a general way to think of this is if you can see the soles of the feet, it's open chain. Not always, but it might be a real easy way to remember for later, for future use. Now, closed chain exercises are performed when the distal part of the extremity is fixed to an object. And so, for example, if you're doing squats or leg press, where the soles of the feet are pressing against something, that's more closed chain. And the way I just kind of categorized when I was trying to learn this, and I was just beating my head against the wall, I'd be like, well, it's just stupid because I can't move my leg around with a leg extension. The big difference that I settled on was, for this one, I can see the soles of the feet. This one I cannot. This one is an open chain. This one's a closed chain, and it got me through grad school. So that might be just enough to help you out. Hopefully it does. I'm pretty sure that'll help you out in terms of the context of quiz questions and test questions going forward. With a TKA, TKAs don't just happen because there's an injury yesterday and they have a TKA today. They're usually anticipated well in advance of the surgery. There's usually a great amount of discomfort and pain that leads to the decision to have a knee replacement. Usually clients will seek out a trainer to help them strengthen pre-operatively. And then when they're actually working out, there's going to be discomfort and pain because of the degenerative condition that's found in the knee that's causing them to have a TKA anyways. So to a certain degree, these clients, you have to take them through a bit of a pain curve when they're pre-op because of the discomfort they're going to have in their knees. And usually they're very agreeable to this because their doctor has said, go out and strengthen up the leg muscles before surgery so you can actually recover a lot faster. So they'll be on board with this, but you just have to be smart about it, right? And I will say this, most knee arthroplasties, hip arthroplasties, shoulder arthroplasties, any kind of replacement like that, you think it's surgery and it's elegant, do yourself a favor, go look up on YouTube knee arthroplasty and sit down, and you'll see it's actually pretty barbaric. There's sawing going on, power tools, drills being done, they're hammering parts into the person's bones. It's pretty barbaric, to say the least. But what happens is this. When people are lying in bed post-op, they'll pretty much say the same thing. The first thing they'll say is like, it's just odd, it's weird. There's like that chronic background noise that I used to have, that pain all the time, it's gone. The surgical pain is there, don't get me wrong. They were hammering components into my body, and drilling into my bones and stuff. That part I feel, but I don't feel that background noise. This is just weird. And so it ends up being a case where it's almost like a blind spot in their body, because they don't have the same degree of proprioception they once had, because all that background noise is gone. It was kind of drowning out the proprioceptive mechanisms in the actual knee itself. So now you have a client who has titanium in their knee joint and perhaps some other components, and as a result, it's not sending any proprioceptive messages back through the central nervous system. So you have to kind of re-educate them on where they are in space. And then there's also a little bit of re-education and kind of trusting the new component, because they can't really feel it and they don't feel the background noise to let them know it's there. So there's going to be a little bit of fear factor when they have to take the first step, excuse the pun, to be able to feel comfortable walking on the thing or whatever they choose to do going forward. Now, I'll tell you, the way the rehab works is many times those people have surgery, they are in recovery, and they usually walk out that day. They have the person up and walking that day. It's unbelievable to watch those people. And they're usually sent home with a pain pump of some variety to help manage the pain. But they can pretty quickly go through physical therapy and end up at your doorstep maybe 1 month or 8 weeks at best post-op. And they're still in a process where you have to teach them how to move and learn where their knee is at any place, any given time. So much like the shoulder, it's an interthyroidal joint. The hip itself is ball and socket, much like the shoulder. It's a very strong joint though. And when we talk about a hip issue or a hip arthroplasty, it ends up being a case where the person itself also has to go through that learning curve to learn where their body is if they have a hip replacement. But the point they make out in the book is post-op hip arthroscopy, recommended protocols, no ballistic or forced stretching. And the concept behind that, where we're up here, is you're not trying to have forceful hip extension, and you're not trying to have anything ballistic for fear of injuring the operated area, the area that was surgically repaired. Now, when I get into arthroplasty, a little bit different, a couple of different things that you can and can't do, but many times your clients will come in and they get uptight about doing any kind of abduction. They're afraid about subluxing their hip because they can't feel where the hip is in space, and they're worried that they're just going to pop that hip right out of socket. And it just takes time for them to get over that. But if you've strengthened them enough on the front end, then there won't be a problem on the back end post-op. And frankly, I don't think I've ever known a person to have a hip subluxation post-op once they've had an arthroplasty. But the thing I want you to remember from this slide is this: with an arthroscopy, no ballistic or forced stretching, all right? With arthritis, it's a degenerative kind of condition. It affects the bones and the joints. Osteoarthritis is progressive destruction of the articular cartilage of a joint. Now, rheumatoid arthritis is different. It's a systemic inflammatory disease affecting joints and connective tissues. You're going to work with both. You're going to see both. But I'm going to tell you, you make sure you differentiate these when you see these later on a test. Okay, guys? Clients can participate in a variety of exercise protocols with osteoarthritis and rheumatoid arthritis. High impact activities are contraindicated for both. Some clients will want to work through some discomfort to retain mobility, which is understandable. But the book seems to focus on contraindications for neck exercises for RA, but it's not specific to cervical. You'll have many times RA will affect the hands. So with that, guys, I breezed through that last little part just to get by 15 minutes. I'm going to sign off right here.